I mean, all of us, it's just so sad that, each one of us here in India has been touched on a personal level. I mean, losing a relative, a friend, a teacher, a colleague, um, a family member, someone, it's really been sad for all our friends across the world. It really has been hard on each one of us. Anupam, do you want to say something?
Anupam Prakash, Dr. Anupam, lot of Anupams here.
Yeah, I know today. Dr. Anupam Prakash, you have something to say?
Anupamas.
Yes. Your hand icon is on.
That was by mistake, sorry.
Okay, cool. So we start in 60 seconds.
Gautam is joining, but he had some problem in finding the link. So,
namaste. It's 6:30 a.m. in LA and Vancouver, 9:30 a.m. in New York. Good morning to our colleagues in the United States and Canada. It's 2:30 in the afternoon in London, 3:30 in Europe. Good afternoon to our colleagues in Europe. It's 7 p.m. in India, 9:30 p.m. in Singapore. Good evening to our friends in different parts of Asia. And at 11:30 p.m., well past bedtime for our colleagues in Australia. Thank you so much for joining. Namaste. A warm welcome to everyone. We will have colleagues from 12 countries joining this session. I'm Anupam Sibal. I'm a pediatric gastroenterologist and group medical director of Apollo Hospitals and the current president of GAPIO. For those who are joining for the first time, GAPIO aims to bring together 1.4 million physicians of Indian origin on one platform, and we now have members from 53 countries. On 11th April last year, with the guidance of the leadership of API, BAPIO, AIMJA, CAPI, and CINI, the Global Indian Physician Collaborative against COVID-19 was launched, and we've had a very fruitful association over the last 13 months. We've met many times, organized some amazing events, and I think we've had the opportunity of learning from each other. So a big thank you to all the associations and their leadership for coming forward. Who would have thought that in 2020, as we approach 2021, as we approach June, we'll be talking about COVID, but there it is. It's day 486 since the COVID pandemic was declared by the WHO. Sadly, there have been 169 million cases with 3.5 million deaths. There's been, of course, an explosion of knowledge that has taken place like never before. If you go on to PubMed Central, you'll find 156,140 papers. That works out to 321 papers a day. And papers from India now are 8,811. So a lot of research happening in India, and we're very happy and proud about that. Today, we will discuss therapeutic options in the management of COVID-19. We have an absolutely stellar group of experts as moderators and speakers. And let me now invite Arun Bhai from Canada to moderate the first two sessions. Dr. Arun Garg is a clinical professor at the University of British Columbia Medical School in laboratory medicine. He's the founder of the Canada-India Network Society, an organization that he's helped build and nurture to solidify relationships between Canada and India. He's also the medical director of the South Asian Health Institute at Fraser Health in BC. He is a distinguished member of the executive committee of GAPIO. Over to you, Arun Bhai.
Thank you, Anupam Bhai. Namaskar from village of Balkara to people from great 12 countries. It's a great privilege and pleasure to moderate next two sessions. And at this time, I would like to introduce Dr. Ram Gopalakrishnan. Dr. Ram Gopalakrishnan is a senior consultant, Institute of Infectious Diseases, Apollo Hospital, Chennai, India. Dr. Ram did his MD, Internal Medicine from PGI Chandigarh, and member of Royal College of Physicians from UK and fellowship in infectious diseases, Wright State University, USA. Dr. Ram is an American board certified internal medicine as well as infectious disease, and is also certified in tropical medicine and traveler's health by American Society of Tropical Medicine and Hygiene. Dr. Ram is an adjunct professor at Dr. MGR Medical University, Tamil Nadu, and Apollo Hospital Education and Research Foundation. Dr. Ram has over 75 research papers to his credit and contributed 5 chapters and given more than 200 invited lectures. Great pleasure to welcome Dr. Ram. Over to you for your presentation.
Okay, thank you very much for that kind introduction. Thank you for giving me this opportunity. My topic today is Remdesivir, a drug that is, I would say, fairly old. And let's see whether there is any new wine in this old bottle or not. So Remdesivir, you know a lot about the drug. Most of you have used this drug at some point in time. It's been used for other viruses. It inhibits RNA-dependent RNA polymerase. And that is the reason why it was probably the first antiviral to be approved for COVID. There are a few things we have learned as we have used this drug for the last year or so. It's been known that it's got an SBECD, alcohol-containing vehicle, which may accumulate if your creatinine clearance is less than 30 and could be nephrotoxic. And the package insert actually says avoid if it's if the creatinine clearance is less than 30. However, there have been studies, real-world studies showing that it's relatively safe. And if you have to use it in a patient with low creatinine clearance, just go right ahead, because we usually get away with just a 5-day course, even without hemodialysis. There is a well-known drug interaction with hydroxychloroquine and some other drug interactions as well. There is also real-world data that it is safe in pregnancy, so don't hesitate to use it if you have to. And the known side effects are relatively mild, largely on the liver, so you have to monitor your liver enzymes when you use the drug. We learned very early on when we used this drug that 5 days equals 10 days. This was the initial New England Journal paper, which showed an equivalent outcome. So if you're using Remdesivir today, the duration of therapy is clearly 5 days. And this was one of the first trials to come out of China on Remdesivir. Unfortunately, this was a futile trial because they ran out of patients. They actually wrapped up their epidemic in 2020 before they could complete the trial. And naturally, they could not show a split in the Kaplan-Meier curves between Remdesivir and placebo, largely because it wasn't powered. They didn't have enough patients to recruit. So this was an inconclusive trial. And therefore, for Remdesivir, we've been heavily dependent upon the ACTT trial from the US NIH, which was initially released in May, and then finally the final report came out in October. The most critical point about the ACTT trial, which we have increasingly realized is the part that is here in which I have put this box in. Note that only about a quarter of the patients were on steroids. This is very important. 23, 21 in these two arms. So this was a trial done largely in patients before corticosteroids were the standard of care. And what did it tell you? It said that you got better quickly, about 5 days quicker, especially if you started your medication within 10 days of symptom onset. They enrolled relatively few patients very early, within 6 days or so. And the benefit was apparent only on a certain oxygen band. Low flow oxygen didn't help if you were on the ventilator or on ECMO. Patients on Remdesivir had fewer adverse events, interestingly, compared with placebo. And it did not show a mortality benefit. There was a trend, but this was not statistically significant by day 29. You can see here that on this scale of oxygen requirement, only level 5 actually benefited from Remdesivir. The others did not benefit. If you required no oxygen or too much oxygen, you did not benefit. It got US FDA provisional approval and final approval in October. And you can see here how the Kaplan-Meier curve split. If you received some oxygen, but the moment you needed a lot of oxygen or you went on NIV, you had no benefit, and certainly it didn't help if you were on mechanical ventilation or ECMO. So it seemed to work only in relatively mildly ill patients. And when we do the forest plot, you can see here as well that only those who received some oxygen did the drug help in, and it also helped if your symptom onset was less than 10 days. So these are the two critical points you can take away. Across the board, it did not help. There was another trial published in JAMA. This was given largely to patients who were not hypoxemic, more than 94% on room air, median day, symptom day 9, and really uncertain clinical importance. So it doesn't help a whole lot if your oxygen levels are pretty good. So that's why nobody really recommends this drug if you are hypoxemic. The biggest study, obviously, to look at Remdesivir was the WHO's Solidarity trial, which was put out much earlier and finally got published in December. And you can see here, this was a mortality trial involving huge numbers. And you can see that the diamond is just across the mean in terms of mortality. It really didn't matter in terms of death. There was absolutely no mortality benefit with regards to Remdesivir. You can see whether you got ventilated or not ventilated, no difference between Remdesivir and controls. And again, the most critical point about the Solidarity trial was that about 47% of patients were on steroids. So you saw that about 23, 24% in ACTT, maybe some benefit. Once you had more and more patients on steroids, probably no benefit. This is an important number to remember here. And when they looked at all the trials of Remdesivir put together in this meta-analysis, you can see here that perhaps there was some benefit in low-risk groups, and again, perhaps some benefit in low flow types, in low flow oxygen here, ACTT2, low flow oxygen here. But overall, there was no benefit when you looked at all the trials put together, the Wuhan trial, ACTT, Solidarity, Simple trial, all of these put together. Now, people are continuing to study Remdesivir. It is in trials with the interferon beta-1a in ACTT3. We don't have this. It has been combined with baricitinib, but that trial was to look at baricitinib. Both arms had Remdesivir. And there's a double-blind placebo-controlled trial. What if you give it very early, within 4 days, just like you give monoclonal antibodies? Would it help or not? That trial is currently ongoing. Now, WHO came out last year after their Solidarity trial and said conditional recommendation against Remdesivir because there was no mortality benefit. So they actually recommend not wasting your time on this drug if you have a limited budget. And these are COVID India guidelines of which I'm part of, and these are yet to be published, but this is what the recommendations will probably look like. Mild to moderate illness recommendation against use, more severe illness in an FiO2 band less than 0.4. Perhaps there may be some benefit in patients who present early, but obviously once you're critically ill, there is no benefit as well. And this is what our Apollo Hospital guidelines look at. We classify patients into mild, moderate, and severe, depending on their oxygen requirement. And in patients who have an FiO2 of less than 0.4, we say that it's optional to use remdesivir. Certainly, if the patient presents very early, requires 2, 3, 4 liters of oxygen, it certainly may help in that setting. But in all other settings where you use steroids, whether you're severely ill or moderately ill, probably you don't get a benefit from remdesivir. So this is what we know on remdesivir. It certainly does not reduce mortality. If you give it very early, it may improve oxygenation and reduce hospital stay. If you're not on oxygen, or if you are on a lot of oxygen or higher levels of support, it does not help. And the real issue is that the two biggest trials did not use a lot of steroids, a minority of patients in both these big trials. We probably will never have a big trial which uses steroids and then study remdesivir as well. So probably no benefit at all in steroid-treated patients. Thank you. That's my last slide. Thank you very much.
Thank you. Thank you, Dr. Ram Gopalakrishnan, for an excellent summary. At this time, I'd like to request Dr. Ravi Mehta to give his presentation. Dr. Ravi Mehta is American Board Certified Pulmonary Medicine and is a senior consultant in interventional pulmonology at Apollo Hospital, Jayanagar, Bangalore. Dr. Mehta is an established clinician, researcher, and a teacher in the field of pulmonology, critical care, and sleep disorders medicine. Dr. Mehta has an extensive academic training and professional experience from United States of America. Over to you, Dr. Mehta, for your presentation.
Thank you very much for the lovely introduction, and thanks Anupam and Apollo for calling us again on this amazing forum, an unprecedented forum, so to say. Following Dr. Ram Gopalakrishnan's presentation, where he has been interacting with all of us for the last 1 year and commendably coming out with these guidelines, we address one more issue, Tocilizumab, in the time given to us. So as a background, he talked a lot of the viral onslaught. So now we now know that inflammation plays a major role. It took around 3 to 4 months into the pandemic to realize that. IL-6, interesting, the entry of the cytokine entity was when this came up as being one of the most important things. And first time in our life, something we had never essayed became something which was available. A target was there, and that's why this became important. The target was Tocilizumab, repurposed from the rheumatology literature, which is known to be a drug used by them, and can it be used for COVID-19 was the question. Of course, before that, steroids were gaining in their name to fame, and it was realized that steroids are like a wide gun over there, targeting every part of the inflammatory cascade, but Toci was more specific. The most important question came that after steroids, is this going to have any value? Is it that after you've given the big blast of anti-inflammatory therapy, will another toned down drug have any sort of role to play or no? And so the story starts early last year, the way the pandemic went. We got bits and pieces of literature which built up, and ultimately we befuddled and went here and there until we finally had some sort of conclusion. So Stop COVID here, July 2020, said that, okay, look at IL-6, maybe high IL-6 may benefit, but it was something which was very presumptive and very initial. Of course, clinicians jumped on it, as happened in the story of COVID, but nevertheless, nobody knew what to do with it and use it or no. And then came the studies, the RCTs, which came from various parts of the world. And an Italian study over there said, nope, not useful. Another one which came from France also said it may be helpful in some patients, but again, did not categorically give us any good information. So these studies went out of the window and did not change practice. Similarly, simultaneously, industry-sponsored studies were coming as every company was trying to show that its drug may work. Both Impacta and Covacta out here had negative outcomes saying that no, the drug does not work. So the initial forays of use and the flurry of activity in the last wave was gradually led to the drug being less used, especially considering the risks of superinfection, the cost issues, and so on. And then came an Indian paper, of which one of our speakers here, Sunita, was also a part of, where an Indian consortium looked at what's going on. And they also said that the routine use was not too great, but they were trying to look at a subset where it may be useful, and left the usual message that look at it carefully in more studies so as to try and give an answer. And then came something which looks like, which was the showstopper, when the jury was still out, which is a study called REMAP-CAP, which has reflected the amazing work done by the world, where randomized control trials could still come as people were floundering and trying to find a way in the pandemic and desperately trying to treat patients. This was a randomized control trial using a fixed dose of tocilizumab. They also tested sarilumab, one more agent over there. And there they found that, yes, finally there is a difference. There was a significant difference in the number of organ support free days, which is very, very important. 10 in the tocilizumab group and 11 in the sarilumab group. Do forgive me, I'll cover this agent side by side because it has been part of the discussion when Toci has been talked about. And there was a big difference compared to the control group, or a significant difference. And this chart reflects the same thing over here. Organ support free days were significant. And the most important thing, we finally had mortality death when it came to in-hospital mortality, 28% versus 22%. And this is where it ultimately panned out that these numbers are similar to what was there for steroids in recovery. And it may be a drug which is useful, was now replaced by, looks like it is useful in the right subset of patients. Another important corollary was the probability of discharge from ICU, which again, as the graph shows over here, was significantly positive in favor of tocilizumab and also sarilumab to a certain extent. And with this major breakthrough, which came in December, came a meta-analysis recently, which looked at 8 major randomized controlled trials and looked at mortality progression to mechanical ventilation and hospital discharge, all of which are concerning important and imperative outcomes of COVID-19, and finally put the matter to rest when they said that tocilizumab has statistically significant benefit. It may not be huge, but it is important considering that very, very few proven therapies. You saw how Dr. Ram told us Remdesivir came and literally is now holding on by a thread to its entire use. Latest, the preprint spectrum, which has been the whole story of COVID-19. If you look at medRxiv, I was going through that yesterday. Sarilumab, again, studied in a RCT, shows that there is an improvement over here in mechanical ventilation, 43% versus 35%, and also a similar thing in mortality, but it's not statistically significant. So again, they're saying that people who get steroids may benefit by sarilumab, and like the Indian message earlier, they're saying more studies are required. So again, at this point, the take-home message from this entire story, we've summarized basically more than 1 year of tocilizumab in 5 minutes. The tocilizumab story reflects the yo-yo of the pandemic. It is actually the return of the phoenix as it was put to rest and not used. Sarilumab is a close second in the trials and still to be validated. We have to put this in the pathophysiological understanding of COVID-19. Anti-inflammatory took center stage. The most important life-saving or outcome-giving entities in the COVID pandemic. And next to steroids, or now trying to show us important role, is tocilizumab. The lesson learned in the pandemic was defining the window of effectivity is the Achilles heel. You may have any drug, but if you don't know when to position it, then you will not be able to get its utility. And this is what has been the story of this drug when you look at the number of trials, especially the heterogeneity, the non-randomized nature, the different times the drug was given. An important message for practitioners: routine IL-6 levels no longer are required except for very few situations. And a very important message, please don't do it after tocilizumab to make any decisions, as it persists to be high because of the blockade of the receptor for a while. Downside of the drug, the immune knockout is there because now it's always standard of care with steroids plus this agent. And opportunistic infections like mucormycosis, we've become like a 10K country. We've had this pandemic of COVID followed by an epidemic of mucor. So you have to put things into perspective, giving us the same wisdom. Whatever you do, use it judiciously, use it appropriately, and use it at the right time. On the right is a brief recommendation out here validated by the IDSA, the Infectious Disease Society of North America, and similarly by the NIH also, that entry-level patients who in the first 48 hours have go on to high-flow oxygen, NIV, HFNC, or ventilator will benefit with this drug in addition to standard of care. And similarly, patients in the hospital who worsen suddenly from low-flow oxygen above with elevated markers will benefit from tocilizumab. These are the two currently accepted indications pending more studies. So this, in a nutshell, is the story of Tocilizumab. Interesting, provocative, but finally has given us some role and validated in most international guidelines as a significant recommendation, albeit with a low to moderate degree of evidence. Thank you very much for the attention, and thanks for inviting me again.
Thank you. Thank you so much, Arun Bhai. Thank you, Ram. Thank you, Ravi. Brilliant presentations, made something that has been debated now for months. In a few minutes, you've kind of clarified it. And listening to both of you, one wonders why there was such a scramble in the past few months about Remdesivir and Tocilizumab. I mean, everybody's phone kept ringing. Arrange Remdesivir, arrange Tocilizumab, and you've so clearly shown that the indications are so limited. We move on to our next moderator, and it's a privilege to invite Dr. Anupama Gotemukula, who is the president-elect of the American Association of Physicians of Indian Origin, API. Anupama is a pediatric anesthetist at Children's Hospital of San Antonio in Texas, and has been a huge pillar of support for this collaborative. Over to you, Anupama.
Thank you, Anupam. It was a kind introduction. So I will be giving just a few numbers before I introduce the next speaker. So United States has been doing great now with the vaccination going at full speed. And I think above 65, already more than 80% have been vaccinated, and 35 to 38% are vaccinated with 2 doses as of now. So the caseload has come down drastically after vaccinations. Yesterday, we had a number 21,968 total cases in all over the country, and only 675 deaths. So it's coming down. So that's a very good news why vaccinations are so important to control this pandemic. So I would like to take this privilege to introduce the speaker, Dr. Sanjay Agarwal. And Dr. Sanjay Agarwal is an experienced and accomplished board-certified critical care specialist, interventional pulmonologist, and sleep specialist practicing in San Francisco, United States. Currently most active as frontline physician warrior at ICU with Kaiser Group of Hospitals. Dr. Sanjay has first-hand experience of using Remdesivir in SARS-CoV-2 infected patients, as well as other treatments that have matured from nascent stages to somewhat more defined approaches now. Dr. Sanjay has also been taking care of patients of novel coronavirus infections in the wards, at the local hospitals, and in the office settings. I welcome Dr. Sanjay Agarwal. Time is yours.
Hi, good morning, everybody from the US and appropriately to all over the world. Thank you, Anupama, for this wonderful introduction. Thank you, Anupam-ji, for calling with me and giving me this opportunity. Can you guys see my screen? I just want to make sure. Okay, so let's start straight with the, so I was asked to talk about the monoclonal antibodies and as to what its use is over the all these other treatment modalities. So what are monoclonal antibodies? These are the laboratory-made proteins. They're not derived from the animals or from the virus. They're lab engineered to serve as the substitute antibodies, which can restore, enhance, or mimic the immune system itself. So the way we have been using the monoclonal antibodies in the medical world for quite some time in different settings for treating the hematologic malignancies like advanced lymphomas or follicular lymphoma, solid tumors, breast cancer, lung cancer, autoimmune disorders like rheumatoid arthritis, hypercholesterolemia, asthma with IL-5 inhibitors, or the anti-IgE therapy, osteoporosis, and a host of other things. So the way it is made is we inject the antigen into the mouse, which produces a plasma, goes to the plasma cell, and it releases an antibody, which is fused together with the tumor cell and causes a hybridoma, which multiplies really faster, and a whole series of monoclonal antibodies. Just a single gene, single clone of this is called monoclonal antibodies. And we have an endless supply of that. And this endless supply of monoclonal antibodies directed towards one antigen. In this case, it is the S protein of the, or maybe a single epitope on the
Dr. Sanjay, can you unmute? You got muted by mistake. Unmute. Dr. Sanjay, unmute. You're still muted.
I am. Okay. Is it better? Can you hear me?
Yes.
Yeah.
Go ahead.
Sorry about that. So I'm going to start this process one more time. So example of monoclonal antibodies. On the left-hand side, you can see that we have been using it.
No, Sanjay, we heard all that. We
Yeah.
lost you when you were talking about the spike protein.
Okay. So the antibodies, when it's given into the human body, and then this is SARS-CoV-2 virus, it identifies that by looking at the spike protein, and the binding sites of these antibodies, they negate or bind with this spike protein, and the ACE inhibitor, the ACE receptors of the human cells are not available, and the whole process just dies out. So that's the process behind the monoclonal antibodies, what it is, how it has been used, and what to do with that. So coming to the next slide. Why is it not going? Okay, so there are numerous studies have been done. The first study published in the NEJM in October 28, 2020. I'm kind of giving a summary. At that time, we knew a lot of knowledge, as Anupam ji already put it in, that more than 150,000 studies which has been published. We have known a lot about this disease in the last 1 year. So this time we knew that it is mostly mild disease, but it can cause severe and life-threatening and cause life. And the viral neutralizing monoclonal antibodies were predicted at the time based on the early experience with plasma therapy, that it can reduce the viral load, it can ameliorate the symptoms and prevent hospitalization. So with that background, the study was designed, and with 452 patients were divided into four different groups of 3 strengths of the monoclonal antibody. And this was done by Lilly, and this was bamlanivimab, 700 milligrams, 2800 milligrams, or 7,000 milligrams, or in a placebo. So these 4 arms, and the primary outcome endpoint was to change of the viral load decrease in 11 days from baseline. And the pre-planned interim analysis was done on September 5th, 2020. And the main results are that the entire population, the decrease in viral load was almost 99.97%. But the interesting thing, we found that the patients with 2,800 milligrams dose in that arm, they did the best compared to even the 7,000 milligram dose, which was kind of off. And it showed that on day 2 to 6, the patient with monoclonal antibody group, or the intervention group, they had slightly lower severity of symptoms than those who received the placebo. And COVID-related hospitalization of ER visit was just 1.6% in this bamlanivimab group versus 6.3% in placebo group. So the symptoms were decreased, the hospitalization was decreased, the ER visit was decreased, and there was a viral load decrease overall. So the conclusion was that in this interim analysis in phase 2 trial, one of the 3 doses only was useful, and it appeared to accelerate the natural decline in the viral load over time. Over the next 6 months, fast forward, we had quite a few studies. I won't bore you with all these words and numbers, but these are the studies which are listed, and they're published in premium journals. And JAMA published the combination therapy of the bamlanivimab and itesivimab, which is the Eli Lilly's cocktail, and it decreased the viral load. This was published in January 21st, after which it was given the emergency use authorization. This was a study I talked about earlier. And the last one I wanted to point out here is the neutralizing monoclonal antibody for hospitalized patients with COVID-19. This is an ongoing trial and ongoing research with the ACTIV-3 and TICO group, which in this study was actually published in March 11. And this was for in-hospital or on oxygen patients, and they did not tend to do well. So the study was halted early. This is the Regeneron cocktail, and this one is the Lilly cocktail, which is available. We're going to talk more about them. So what is monoclonal antibody therapy? What does it mean? With all those studies which I just now listed, we came to this conclusion that this antibody, which is the antigen binding site which identifies the SARS, and this is the domain, which identifies the S protein epitopes. The antigen is, in this case, is SARS-CoV-2 virus and this whole antibody. And we have two monoclonal antibody cocktails, as I already alluded to. One of them is Lilly, that's bamlanivimab and the Atezolizumab. And the other one is from Regeneron, the Regeneron cocktail, which we can talk about that. So these two monoclonal antibody cocktails are given FDA, EUA, emergency use authorizations for treatment. And I want you to focus on all these conditions. I'm going to go over them one more time. It is for mild to moderate COVID-19 patients only. So you have to choose only those who are in the category of mild to moderate with no oxygen requirement and SaO2 more than 90%, 94%. It should be in the non-hospitalized patients. It's allowed for more than or equal to 12 years of age. And it has to have a laboratory confirmed infection, antigen by SARS, antigen analysis or RT-PCR. And this is for the patients who are at high risk for progressing to severe disease or hospitalization. So all these categories are important. So these are the decision-making points where the emergency use authorization was provided. And the FDA has guidelines for both these cocktails. Now, emergency use authorization is still an off-label use. It does not give you authority to use. It's not FDA approval. So a consent has to be obtained from the patient when you are giving these cocktails. You should administer as soon as possible after a positive SARS-2 test has been provided, and it should be within the first 10 days of symptom onset. Infectious Disease Society of America or FDA or NIH in the US in 2021, all these papers were published in January 21, and they all concur with initial data point. As soon as you get it, you should be able to give, diagnose if these patients fall into these categories. The patient should be considered for monoclonal antibody therapy. A point of note here is there is
Sanjay, could you be a bit louder, please? Sorry to interrupt. Could you be a bit louder? Yeah.
So, the point of concern here is there is a lot of variants have been showing up, and these monoclonal antibody cocktails have been found to incite, or there's a bypass of these viruses to cause more variants. So you need to have the knowledge of the local prevalence of SARS-CoV-2 variants when evaluating the treatment options, because of increasing number of the SARS-CoV-2 variants that are resistant to bamlanivimab alone. And that's why FDA has recently revoked the emergency use authorization for BAM itself. And it's not available since April 26. It's not available in the US. So I mentioned about the high-risk patients for EUA. For the antibody, they has to be non-hospitalized. Patient has to be greater than 12 years of age. Weight has to be greater than 40 kilograms. And those who are at high risk, I mentioned that in the previous slide. So who are these high-risk patients? How are they defined? So they have to be, for those high-risk patients, the BMI has to be greater than 35 kilogram per meter square. They have to have chronic kidney disease or diabetes mellitus, which is controlled or non-controlled, immunocompromised conditions, or currently receiving any immunosuppressive treatment, or age greater than 65 years. So these are high-risk candidates. If their age is greater than 55 years, they should also have a comorbid condition of hypertension or cardiovascular disease, or COPD, or any other chronic respiratory disease which requires care. For age between 12 to 17 years, either the BMI is greater than 85th percentile of age and gender from CDC guidelines, or have a sickle cell disease or congenital heart or lung disease, or any kind of neurodevelopmental disorder like cerebral palsy, or a medical-related technological dependence not related to COVID, like tracheostomy, gastrostomy, positive pressure ventilation, etc., or asthma or any other chronic respiratory disease. So these were the guidelines which were initially passed in January or February when emergency use authorization was given to both these cocktails. But last week, FDA also broadened the category a little bit, giving more leeway to the providers who are considering monoclonal antibodies for the patients, and they can be given for slightly more relaxed conditions than these strict rules. So the two cocktails I was mentioning about, one of them is from Lilly and Company, the bamlanivimab 700 milligrams and Atezolizumab 1400 milligrams. They have to be given in a single dose over about 60 minutes. And these are 60 minutes. And these are available in the US, but bamlanivimab, which was initially received emergency use authorization based on the study on November 10, 2020, is withdrawn on 16th of April. So emergency use authorization can be withdrawn as well from this example. And this was because there was a lot of variance was found by using this medication alone. But if we use bamlanivimab and intesivimab together, then the effect was better and variants were less, even though about 8 states, even this cocktail is not available in the US. The second cocktail was the Regeneron cocktail, the Tocilizumab 1200 milligrams and Imdevimab 1200 milligrams. And this is from Regeneron. It is also received an emergency use authorization in India last week. It's going to be marketed by Cipla, and it will cost about 60,000 rupees per dose, apparently. All these 4 molecules, they are directed towards the S protein of the SARS-CoV-2 virus. Now, interestingly, they just last week on May 26th, a third monoclonal antibody, which was manufactured by GSK with the help of Vir Pharma, it's called Sotrovimab. It was granted emergency use authorization as well. It's a single drug, again, given as IV infusion in single setting, and it is also found to be active against the UK variant, the South African variant, California variant, or even the Indian variant found recently. And you can find all these data in the examples listed here. So both these cocktails can be given over IV over 1 hour, and the infusion center help is needed. There's no dosing adjustment needed for renal impairment or mild hepatic impairment. But for moderate or severe hepatic impairment, no adjustment was provided because it has not been studied. FDA does not authorize the use of monoclonal antibodies for hospitalized patients or those who require oxygen or have increased need for oxygen therapy for any kind of chronic lung or heart disease due to COVID-19 outside of a clinical trial. And that trial I was mentioning is ongoing by the active study group. They are still actively enrolling patients for the hospitalized or the oxygen need variety. So outside that clinical trial settings, it's not supposed to be used in the hospitalized or oxygen requirement because the outcomes may be worse if it's used on patients with high flow or mechanical ventilation. As I mentioned, we should have a we should have the concern about the variants which are coming through with these monoclonal antibodies. What about in pregnancy and in children?
Sanjay, if I might request you to please speed up a bit because we've got a long list of speakers.
Almost done. So in pregnancy, basically the monoclonal antibodies just crosses the placenta. It should not be withheld from a pregnant patient if they meet the criteria. In children, there's insufficient data to recommend either for or against the monoclonal antibodies for children. Most children with mild, moderate COVID-19 disease, even with risk factors, will not progress to severe illness and will recover without the monoclonal antibodies. Diverse effects in Blazewell trial, we found that the patient was having nausea, diarrhea, dizziness, headache, pruritus, and vomiting. And in EU fact sheet for the Regeneron monoclonal antibodies, it was that only 1 among the 533 participants had anaphylactic reaction. So it's fairly safe. Vaccination status, vaccination should be deferred for about 90 days after receiving the monoclonal antibodies as a precautionary measure. And for people who have developed COVID-19 after vaccination, the prior vaccination should not affect the treatment decisions. There's not many drug-drug interactions, and it's fairly safe in that way. With this, I hand it over back to Dr. Gautam Mukula. Thank you.
Thank you, Sanjay. That was very useful information, since that's the one which is very promising right now for treating COVID. And I would like to take privilege to introduce our next speaker, Dr. Sushmita Roy Chowdhury. Dr. Sushmita Roy Chowdhury is working as Senior Consultant Pulmonologist at Fortis Hospitals, Kolkata. Dr. Sushmita has more than 18 years of experience and specializes in pulmonology, sleep medicine, allergy, and asthma. Dr. Sushmita is doing research on metabolomics in ILD and airways disease in collaboration with IIT Kharagpur. And one initial paper has been published on this research. And Dr. Sushmita was tutor at Glasgow University for 3 years and regularly teaching DNB trainees. Welcome, Dr. Sushmita. The stage is yours.
Thank you very much for the kind introduction. And thank you, Dr. Sybil and Dr. Tandon, for having me back. Always a pleasure to be here. I was asked to speak about Favipiravir. So basically, this has been pretty much in use recently because of lots of drugs not being available. So quick recap, it's a repurposed oral drug, which was discovered while screening from a chemical library of drugs that might be useful in treating influenza during the influenza pandemic in Japan in 2014. And it was found it's a pro-drug which had in vitro activity against SARS-CoV-2. So when there was an onslaught, obviously this was one on the list. So the principle behind its use is that in any antiviral infection which really affects the body, it is hit early and hit hard as the viral illness comes onto you, as early as the pre-symptomatic viral load stage, so that the viral load under the curve can be reduced significantly. And effectively, the principle means that it should be reducing the duration of shedding and the effector immune response, which then causes more damage than just the infection from the virus. Quickly about the mechanism of action. So Favipiravir itself is a prodrug, which is converted into the Favipiravir RTP variant, which is a potent inhibitor of the RNA-dependent RNA polymerase, which leads to chain transmission, chain termination, and viral mutagenesis, because the combination has a cytopathic effect and a mutagenic effect on the virus, leading to reduction in the number of viral RNA. RP exists in various types of viruses, enabling a broader spectrum of antiviral use. And as you can see, Favipiravir alone is no good. Incorporated on phosphoribosylated into Favipiravir RMP and RTP combination is the active form, which then inhibits the RDRTP, which then stops the replication of the virus. And that is how it was supposed to work. So the in vitro evidence was showed in studies from China and also from Russia. And the clinical evidence was shown only from non-randomized trials, quite a few, especially the one from Kai, where 80 people were involved. And these studies were mostly done in China, in Thailand, and registries taken from Russia, where it was then included when there was an onslaught of the virus and Remdesivir, etc., was not available. The Indian data for us mainly came from Udwadia group from Maharashtra, and Maharashtra Task Force was the first one to include it, where they included 150 randomized patients who were given 1800 milligrams twice a day for day 1 and 800 milligram twice a day for day 2 to day 14 in patients who had mild and moderate disease on an oral basis and an outpatient setting. And the conclusions from the study was that Favipiravir, if administered early, may, the word is may, reduce clinical signs and symptoms in mild to moderate COVID. The good thing was that it was well tolerated, but the primary endpoint of time to RT-PCR negativity was not achieved statistically. Therefore, it was said that a larger randomized trial is needed. And it was left at that, but it was quite widely used during a period in Maharashtra and other parts of India as well, with mixed results clinically as seen by experience of physicians who used it. Picklington et al., in a review of the safety of Favipiravir, included about 4,000 plus patients, showed that serious adverse effects were less than in 1.1%. And the common side effects with this drug are gastritis, nausea, transaminitis, hyperuricemia, importantly decreased neutrophil counts, and some may show psychiatric manifestations, but very rarely. The contraindications to use of Favipiravir are pregnancy and lactation, those having severe hepatic and renal impairment, and obviously those showing hypersensitivity reactions. So the current status of Favipiravir at the moment is that it appears to be useful in mild to moderate disease, but large randomized controlled trials are required to demonstrate if this effect translates to clinical benefits, as shortening of the disease course, early hospital discharge, and reducing oxygen requirements still need to be proven. And in summary, it is a repurposed oral antiviral agent which inhibits RNA-dependent RNA polymerase, which has cytopathic and mutagenic effects causing reduced viral numbers. is recommended in mild to moderate disease as early as possible. It appears to be useful, but large RCTs need to prove it. And it is not included in the comprehensive national guidelines for management of COVID-19 in India, which was published 5 days ago. And I end with a confession that I have not used it till date. Thank you very much.
Thank you. Thank you so much, Anupama. Thank you, Sushmita. And thank you, Sanjay. Again, two brilliant talks and very well moderated, Anupama. The good news is that we finally have something to keep patients out of hospital. And so we are really delighted that the cocktail is now available. And having said that, patients have started to benefit in the last 48 hours from the availability, with the availability of the cocktail. So thank you for giving us, real world experience from the US, where you've used it for several months, starting off, with the big sensational news of President Trump getting it first. Sushmita, thank you so much for really talking about a drug that has been used a lot, because I guess it's oral. And that's what's been very attractive about it. But like you said, it's not part of any guidelines. We are going to slightly change the order with the permission of Pooja and Dr. Balaji, because Sunita has another talk much in demand tonight. So if you're okay, I'm going to now take the opportunity of inviting Rohini. Dr. Rohini Sridhar is the Chief Operating Officer of the Madurai region for Apollo Hospitals. She's been leading the vaccination program for the group. She's a Joint Secretary of GAPIO and a key member of the Women's Forum of GAPIO. I'm going to request Rohini to introduce Sunita. Over to you, Rohini.
Thank you, Dr. Anupam. It's an absolute pleasure to be a part of this information-packed yet extremely pertinent session on therapeutic options in COVID-19 disease. I also have the privilege today of introducing Dr. Sunita Nareddy. Dr. Sunita Nareddy is certified by the American Board of Internal Medicine in Infectious Disease and is the infectious disease consultant at the Apollo Hospitals, Hyderabad. Dr. Sunita's area of expertise includes nosocomial infections, infections in immunocompromised host, HIV, complicated infections like fungal infections, multi-drug resistant tuberculosis, H1N1, and travel medicine. I have absolute pleasure in inviting Dr. Sunita to make her presentation on interferon and 2DG.
Sunita, just unmute yourself.
Oh, thank you. Thank you. Sorry about that. So today I'll be talking about interferons, molnupiravir, and 2DG. To start with interferons, interferons are a family of cytokines with antiviral properties. They have been suggested as potential treatment for COVID-19 because they have both in vitro and in vivo antiviral properties. Interferons act by inhibition of viral replication by slowing cellular metabolism, interfering with the membrane formation required for viral replication, and inducing cytokines that promote adaptive immunity. In coronaviruses, they encode multiple proteins that antagonize cellular interferon signaling pathways, and this is what is used in the, this is the reason why interferons are being considered. So what is the role in COVID? 10% of the patients with life-threatening COVID have neutralizing type 1 interferon antibodies. So this is why they're considering interferons. But we also notice that there can be either a reduced interferon response in some studies, and in some studies they've shown there's an increased interferon response. So there's actually some conflicting data as well. The in vitro studies with interferon alpha, beta, and gamma have each demonstrated inhibitory activity against SARS-CoV-2, but that is in vitro studies. In animal studies, there have been mixed reports. Interferon alpha and beta showed some protective effects against SARS-CoV and MERS-CoV in mice and macaques. Interferon gamma showed some protective effects against SARS-CoV-2 in mice, whereas there were also worse outcomes in mouse models with SARS and MERS with delayed administration of interferons. So what is the other information we have at this point? Phase 2 randomized placebo-controlled trial with nebulized interferons were done. There was also phase 2 randomized trials with subcutaneous interferons. There were some two randomized control trials with interferon beta included in the Solidarity trial, and and one open label trial with interferon combined with lopinavir, ritonavir, and ribavirin. The first study, the nebulized interferon beta, it was associated with an improved outcome as 6 out of 48 patients in the interferon group versus 11 out of 51 in the placebo group developed severe disease and died. Now, this was a phase 2 trial. But in the larger of the phase 2 trials, there was no virologic benefit in outpatients with mild to moderate SARS-CoV-2, whereas a smaller study reported viral loads, lower viral loads at day 7. So we do have some conflicting data, some showing benefit and some showing no benefits. With the open label trial, the strongest signal of efficacy was a shorter time to viral clearance and more rapid clinical improvement, but this was using interferon beta in combination with lopinavir and ribavirin. There is also another phase 3 trial that is being planned, that's going on, and there's one being planned with inhaled interferon alpha. But right now, the data is not strong enough, and the NIH treatment guidelines recommends against the use of interferons for the treatment of severely ill patients with COVID-19 and do not have any recommendation for the use of interferons in earlier disease. What about the adverse effects? Interferon alpha has more side effects, particularly with flu-like symptoms, nausea, fatigue, weight loss, hematological toxicities, transaminitis, and psychiatric problems, which we have seen in the past as well when we used it for other diseases as well. Interferon beta is generally a little bit better tolerated than interferon alpha. And we also have to worry about the drug-drug interactions, especially if you use other immunomodulators and chemotherapeutic agents, which are fairly abused right now in COVID. Switching gears, we'll talk about molnupiravir. Now, molnupiravir is a broad-spectrum oral antiviral drug. Because it is broad spectrum and because it's oral, it's very attractive to use. It's basically, chemically, molnupiravir is an isopropyl ester prodrug of the ribonucleoside analog of beta-D N4 hydroxycytidine. It is tested for RNA viruses, including SARS-CoV-2, SARS-CoV, and MERS-CoV. It's also been tried with the influenza virus. How does it work? It incorporates new RNA strands and results in the introduction of mutations during subsequent rounds of replication. It has a broad spectrum of activity against a lot of the coronaviruses, and it is active in primary human airway epithelial cells. It reduces viral levels and decreases lung damage in mouse models and also in ferret models. What is the data we have from research? There is a phase 1 dose ranging study in which they've used a 5-day course of oral therapy in healthy adults and found that no evidence of toxicity was there compared with the placebo group at the detected levels that they wanted to have based on animal model studies. Phase 2 trials examined various virological endpoints. They tried 200, 400, and 800 twice a day. Compared that with the placebo in non-hospitalized COVID patients with mild disease. Among these, among the 78 patients with positive baseline PCRs and cultures, 6 out of 25 in the when they compared the two between the placebo and the molnupiravir group, there was an improved response in the molnupiravir group as compared to the placebo. And the other trials, the large phase 2 and 3 trials in hospitalized patients began in October, and the study is still not out as yet. And we have also started several phase 3 trials in India as well. So we are waiting for the data to come out. Molnupiravir is not being studied in pregnant women or women who might become pregnant because of the potential of mutagenesis. So it is generally considered to be a fairly safe and well-tolerated medication, no major side effects. Moving on to 2DG, this is the talk of the town as far as India is concerned. Unfortunately, we do not have too much data, which is going to make it difficult for us to talk about this drug. 2-DG is an anti-glucose metabolite, which was initially actually used, studied in cancer chemotherapy, where they were giving this as an adjunct for radiation therapy. They were giving this along with radiation therapy, and because glucose is required in the metabolism in the brain, this accumulates in the glioblastoma, and then after they were giving the radiation therapy. That's where it was initially studied. So in India, it's been studied by Institute of Nuclear Medicine and Allied Sciences along with the DRDO. Again, the details are not out as yet. The reason they're saying is that because the centers where they've done these studies are all inundated with COVID, and they're not able to complete the data submission. So that's the reason why the data is not out as yet. But whatever information we have is what I have written here. Based on the results of the phase 2 and 3 studies conducted in patients hospitalized with moderate to severe COVID in India, 2-DG has received emergency use authorization as adjunct therapy in moderate to severe COVID patients. Studies were done in multiple centers across the country, about 17 centers, including Delhi Apollo, I'm told. The initial studies were done in terms of dosing studies with various doses, and they found that 90 milligram per kg per day would be the ideal dose. And this was administered twice a day, orally or by Ryle's tube. And the way the hypothesis is, the way it works is by it binds to the glycoprotein folding and binds in the causes basically it binds into the viral RNA and causes disruption of the virus itself. And so that it's supposed to have both antiviral as well as anti-inflammatory properties, which is one thing the author's quote is useful, particularly in COVID. It's also supposed to have other activity in other pathogens, including fungi in some studies as well. Based on the study that was done, they've taken two groups of patients, both the control arm was a standard of care arm, and the treatment arm was 2-DG along with the standard of care. And they found that the 2-DG, when added along with the standard of care, led to significant faster clinical improvement in COVID-19 patients in the phase 2 trial, with the median time to 2-point improvement on the WHO ordinal scale being 4.5 days in the 2-DG arm versus 8 days in the standard of care arm, which was very promising, which led to the phase 3 trials, which was done in moderate to severe COVID-19 patients. Some of the exclusion criteria, they've told that in this study included, they did not include patients with uncontrolled diabetes. They did include patients with controlled diabetes, as well as people with other medical comorbidities like significant liver and kidney damage and so on. 2-DG, in this study, the authors said that the 2-DG led to higher proportion of subjects improving to the score of 3 and 4 on the WHO ordinal scale by day 3, which was much more than the standard of care arm, which is 42 to 31 versus 31% for the score 4 and 11 to versus 6 in the score 3. They also said that there's early relief from oxygen therapy, which was which looks very promising, but we have to wait and see. And at discharge, more patients under the 2-DG arm had viral PCR negatives as compared to the standard of care. And there were no major safety issues reported in the trial. And again, the most promising thing that they talk about is a decrease in oxygen dependence. So I'll stop here and thank Dr. Sneha for helping me prepare this.
Thank you so much, Sunita, and thank you, Rohini. I would now take this opportunity to invite Professor Gautam Bodiwala to moderate the next 2 sessions. Professor Bodiwala is acknowledged as one of the pioneers in the field of emergency medicine globally, past president of the International Federation for Emergency Medicine, He's a distinguished executive committee member of CAPIO. He was awarded the Commander of British Empire, CBE, by Her Majesty, the first to an emergency medicine consultant. And what can be a greater testament to the respect that he enjoys, that the emergency department in Leicester is known as the Gautam Bodhiwala Emergency Department, the only one of its kind in UK. Professor Gautam Bodhiwala.
No problem. Thank you for that very kind introduction. It's a great pleasure to invite Pooja Shah as a next speaker. Pooja is an infectious disease consultant and she practices in New Jersey. Pooja completed her medical residency in Newark, New Jersey, and obtained her fellowship in infectious disease from Carolina University, Wyden Medical Center. Pooja was the principal investigator for expanded access program with Gilead involving drug Remdesivir in the JFK University Hospital in New Jersey. Pooja, the stage is yours. Thank you very much.
Thank you very much for having me here today. I'm going to be speaking about Tocilizumab. So Tocilizumab is basically an anti-CD6 humanized monoclonal antibody. It binds to the domain 1 of human CD6. It has been approved in India for treatment of moderate to severe chronic plaque psoriasis back in 2013, but now it's being repurposed for the use for COVID-19 patients. Cuba is the first country to approve a single-arm clinical trial and expanded access use of the drug for COVID-19 patients. And India has a phase 2 trial that was conducted back in 2020 with 30 patients. So the mechanism of action for Tocilizumab.
Sorry, Pooja, you might want to start your slideshow because we're stuck at the title slide.
I'm sorry?
We're stuck at the title slide. So if you're moving your slides, we can see them.
It's moving here. Let's see.
Yeah, no, just go on to slideshow.
Okay. Now, can you see it?
Yeah, but just go on to slideshow so that we have the full screen.
It is in. Okay. I have it in slideshow.
Okay, never mind. Just so, yeah, keep moving your slides, please. Thanks.
You see it now?
Yeah.
So Tocilizumab is, as we know, with COVID-19 patients, there's a lot of inflammation associated with the progression of the disease. And it comes from reactivating our immune system in response to the virus. So Tocilizumab is an antibody that recognizes a protein expressed in the immune system. It reduces the expression of intracellular proteins involved in activation. It inhibits proliferation of the T cells. And it's also associated with reduction of the secretion of the pro-inflammatory cytokines such as IL-6. The medicine has a unique mechanism of action in helping reduce the cytokine release syndrome. As you can see in this picture here, this is the side of a cytokine storm in a COVID-19 patient. You can see there's a lot of inflammation and a lot of cells being activated.
Pooja, your slides are not moving.
I don't know why it's not. Is this better if I do it this way?
Yeah, sure. Yeah, yeah. Now we can see the figure with the cytokine storm. Yeah.
Yeah. Okay. So as you can see, this is the cytokine storm with a lot of inflammation, cells being activated, and this is without using the drug. And with the drug, you can see it reduces the cytokine storm. So there is a phase 2 open label randomized placebo control trial that has been conducted in India to study this drug and the safety of the drug, especially in treating moderate to severe acute respiratory distress syndrome due to cytokine release in COVID-19 patients. The study was conducted at 2 hospitals in New Delhi and 2 hospitals in Mumbai. It's a multi-centric open label study, 2-arm controlled. It's randomized 2-to-1 ratio. It's a phase 2 study, and they did follow up the patients 30 days afterwards, and it was conducted between May 2nd, 2020 to July 7, 2020. All the study subjects were males and females over the age of 18 years old. They all had positive infection, and they were in the hospital due to clinical worsening oxygen saturation, less than 94%. They all presented with moderate to severe ARDS, and they might have high levels of pro-inflammatory markers to qualify for this study. and all of them required different types of oxygen therapy, such as NRB, venturi mask, the BiPAP, CPAP, and the face mask. As you can see in this study, they initially enrolled 36 patients, but they had to exclude 4 patients because they didn't meet criteria. And what they did is they had initially 22 patients who were given the drug and 10 patients that were not given the drug. So they called it Arm A and Arm B. However, in Arm A, they had to exclude 2 patients. So in the end, they had only 20 patients that were given tocilizumab, and 10 patients were not given the medicine. And all these patients, they did have supportive care, including oxygen, antibiotics, antivirals, steroids, heparin, vitamin supplements as well. The exclusion criteria: anybody with severe allergic reactions to monoclonal antibodies, if they had active TB, or they were inadequately treated for TB or latent TB, if taking oral anti-rejection or any immunosuppressive drugs in the last 6 months, they were in other clinical trials involving IL-6 therapy, known history of having Hep B, C, or HIV, and if they had a low ANC or platelet count, were excluded. The dosing they were using was 0.4 to 1.6 mg per kg, and some patients, based on their clinical experience, were getting weekly regimen doses of the medicine, and they were not infusing any other medications at the same time as the drug. So what did the results of the trial show? That there were no deaths in Arm A, which was the patients who got the medicine, and there were 3 deaths reported in Arm B, and those who did not receive the medication. And what they also noticed in Arm A, there was a lung function was determined by the oxygen saturation, and they have improved or they were stabilized without increasing the FiO2. Also, the inflammatory markers, there was a reduction in the ferritin in Arm A. However, D-dimer, LDH, and CRP were non-significant between the 2 groups. However, they did notice the IL-6 levels in the TNF-alpha had a significant decline in post-infusion of the medicine. The safety and side effects, they noticed there were transient lymphopenia, infusion reactions such as nausea, rash, flushing, cough, wheezing, dyspnea, seen in about 12 to 15%, and there were a couple patients with anaphylactic reactions. So the conclusion is that this trial has led the medicine to be approved in India with restricted emergency use. They found it to be safe and effective in treatment for cytokine release syndrome, including ARDS. There was some survival and recovery benefit. However, it does call for continued investigation through larger and controlled trials. And then other studies and cases involving the drug included, there was a retrospective study published that showed 25 patients with moderate to severe COVID-19 disease with high levels of pro-inflammatory markers and worsening pulmonary function. The conclusion of the study showed that a single dose helped accelerate recovery in adult patients, reduction in their inflammatory markers, weaning off oxygen, and reduced length of stay. There was another retrospective study showing of 27 patients showing similar outcomes, best supportive care, and showed a reduction in inflammatory markers and improvement in oxygen saturation. And also helps shown to accelerate recovery time in hospital patients. Lastly, there has been there was a study done that showed report of 3 cases showing the effect of tocilizumab. So in the first patient, it was a 53-year-old woman. She had hypertension, diabetes. Her symptoms started back March 23rd. Cough, shortness of breath. They were positive for COVID on March 26th. Her chest X-ray showed interstitial lesions in both lungs. She was started on therapy medications. As you can see, a combination. She was eventually intubated, and on day 13 of the admission, she had worsening interstitial pneumonia, elevated ALP, LDH, ESR, D-dimer. So they gave her tocilizumab, was administered, and 48 hours later, they saw the PO2 and FiO2 improve. Eventually, she was extubated after the first dose. They did give her a second dose, which made her even clinically better. They also noticed IL-6 and AST was reduced with no adverse reactions. And you can see in this is her chest X-ray prior to giving her the medications.
Sorry to interrupt, but could you speed up a bit? Sorry.
Sure. I am almost done. Yeah. As you can see, and then after the drug, this was given. There was the second patient who was an 89-year-old male. He had multiple comorbidities. He was alcoholic. He also presented similar symptoms. He had biopulmonary infiltrates. He was intubated, high leukocytes, AST, ALDH. They gave him multiple treatments. They gave it tocilizumab. He initially got better, but eventually he got worse. He had pneumothorax, and then unfortunately he passed away due to mixed cardiovascular and respiratory failure. Our third patient was an 81-year-old female, hypertension, diabetes. She was not intubated at this time, but they classified her as severe because of requiring high amounts of oxygen. They also gave her tocilizumab when she was admitted to the ICU. 2 days later, she improved with respiratory distress. Her IL-6 was reduced. And as you can see, also her X-ray, this is pre and post-treatment, has improved, and she was eventually discharged. So the take home was that even though tocilizumab was given in combination with other antiviral therapies, it did reduce the IL-6 concentration. There's safety. They did note that there was no opportunistic secondary infections, but however, this was last year, and as we're learning more and more, there is risk for opportunistic infections now with administration of steroids and immunosuppressive therapy at this time. So in conclusion, for now, tocilizumab gives physicians therapeutic option to potentially save lives for COVID-19 patients. It accelerates recovery time in hospital. In India, it's approved for restricted use. It has some safety and effective immunotherapy for ARDS. However, there needs to be further larger control trials need to be studied to understand the drug better. And thank you.
Thank you, Pooja. That was wonderful.
Thank
After
you.
Pooja, Balaji has no option but to appear. Let me try and invoke him. Our next speaker is Dr. A.V. Balaji, who is my neighbor, as a matter of fact. He comes from Birmingham. He's a consultant at Acute Medicine and Infectious Disease Hospital and a lead clinician in acute medicine department at Heartland Hospitals in Birmingham. Having completed his training in tropical medicine, Dr. Balaji completed his training in infectious disease and internal medicine in the area around Birmingham. He has got special interest in tuberculosis and acute infectious disease medicine. And he is very much involved in teaching undergraduates as well as postgraduates, especially focusing on clinical approach to a presentation. I present to you Dr. A.V. Balaji. Thank you.
Thank you very much. Thank you for the kind introduction. I hope you all can hear me. Yes.
Yes, we can.
Thank you. So yeah, I've been asked to talk on a very small molecule, baricitinib, and its use in COVID. So the way I'm going to do it is I will stick to the restriction. I didn't realize that I was allowed more than 5 slides, so I just did it in 5 slides. So we're going to look at what is it, what is its role in COVID, and if I do have time, what is our experience on it, which I can tell you beforehand, none. Okay, so what is baricitinib? Let's see if it moves. Right?
Yeah.
So, as I said, it's a small orally active drug. It is a Janus kinase inhibitor. Now, and it's mainly used for its immunomodulatory properties in rheumatoid arthritis. Now, how does it work? It basically, the Janus kinases actually induce the proteins called STAT, which then dimerize after being phosphorylated and get into the nucleus and either activate or block transcription of further proteins. Now, baricitinib actually blocks that action. Now, how does that action transfer or translate into our use in COVID as well as in rheumatoid arthritis? So rheumatoid arthritis, you know, it just modulates all the antibodies which are released. So the critical signal transduction to the nucleus from the common gamma chain of the plasma membrane receptors for interleukins are blocked. Now, we'll come to the COVID part. Like with any biologicals or any drugs, you will have side effects. And what are the side effects of baricitinib? Similar to disease modifying rheumatological agents and increased risk of infections, liver function abnormalities, neutropenia, hyperlipidemia, risk of venous thromboembolism, and possible increased serum creatinine. Now, some anecdotal reports of increased herpes lesions have also been seen in certain Asian countries, but I believe that's not that important for us because rheumatologists have been using these medications for the past 2 years without any significant side effects. Yes, you cannot use it in pregnancy.
But that was the baricitinib for rheumatoid arthritis. Now, how did it come into COVID? So the baricitinib was noted to be useful after the ACTT or the adaptive COVID-19 trial 2, when it was combined with remdesivir, which our first speaker, Dr. Gopalakrishnan, was alluding to. It was used in a combination on nearly 1,000 patients in a double-blind, multi-center randomized controlled trial. Now, what we saw, there were two groups. One was baricitinib with remdesivir, and the other one was a placebo with remdesivir. And the median time to recovery in the combination of baricitinib and remdesivir was 7 days compared to 8 days in the placebo. But the time to recovery among patients receiving high flow oxygen or non-invasive ventilation was 10 days compared to 18 days in the placebo arm. Serious adverse effects were 16 versus 21%. So the conclusion was baricitinib plus remdesivir reduced the recovery time and accelerated improvement in the clinical status. Now, does that translate into use? Now, so what happened was there was an emergency use authorization by the US FDA for the use along with remdesivir. So the only other paper which came out, again in New England Journal, and I have based my whole study on New England Journal only, was that they looked at evidence-based efficacy of COVID-19 therapies according to disease severity. And as few speakers have alluded to before, the severity was divided into from a scale of 1 to 8, where 1 is the not hospitalized patient, to 8, where the patient is actually dead. Now, if you look at baricitinib there, it is most effective based on the study which we saw on stages 5 and 6, which means hospital supplemental oxygen, patients having hospitalized and having supplemental oxygen, or hospitalized patients with NIV or high flow oxygen devices. That's where the actual effect was felt. Now, it's not in my remit to talk about the others, but you can look at the graph and you can work out the drugs which are above baricitinib. So what do we see in COVID then? So baricitinib, based on its mechanism of action, can be thought to dampen the cytokine storm, which we see in COVID in the second week of the illness. And also, it is also thought to have potential antiviral effects and prevents the endocytosis of the virus by the cell. Again, it's a Janus kinase inhibitor property. The dose recommended was 4 milligrams for up to 14 days, but the recommendation was only in combination with remdesivir in patients who require oxygen or ventilatory support. It only appears to modestly improve the time to recovery, and the recommendation is it should not be used without remdesivir. Now, there are lots of questions which will come for people, meaning for me in the UK, it's very tightly guided. So I will not, or I do not have a chance to use it on my own. It has to come via the recovery trial, which is our main basis for management of COVID in the UK. So any recommendation on management of COVID in the UK comes via the recommendations from whatever is found from the recovery trial. And at present, I can tell you that we are most happy using the dexamethasone. Remdesivir came in the initial period and then it backed out, but Tocilizumab is quite promising and it is being used in patients who are in the ITU setting. Now, so the answer from me, should we use it or not? Should we use it independently? Could we use it with the patients who are on dexamethasone? We need more studies, meaning we wouldn't be making any recommendation that way. And my plea to all of you is that please make sure that the results are all evidence-based before anything can be used, because you know that these are immunomodulatory drugs. And if we use it without a proper cover, it might end up doing a lot more harm than good. That is my talk. Thank you very much.
Thank you.
Thank you so much, Professor Gautam. Thank you, Dr. Balaji, Pooja. And over to Rohini to introduce our final speaker. Over to you, Rohini.
Thank you, Dr. Anupam. I have great pleasure in introducing Dr. Anupam Prakash, who's the Professor of Medicine and Head of the Department of Accident and Emergency Medicine at the Lady Hardinge Medical College. He's the Editor-in-Chief of the Indian Journal of Medical Specialties and the Associate Editor of the 10th and the 11th edition of the API Textbook of Medicine. He has authored 8 books and several publications. He's the principal investigator of 12 phase 3 international trials, guided 8 STS and 15 PG theses. He's currently the president of the Delhi Diabetic Forum and the Indian Society for Atherosclerosis Research, and also a member of the governing body of APE. I welcome Dr. Anupam Prakash to give his talk on ivermectin.
Thank you, madam, and thank you, the organizers, for giving me an opportunity to present something which probably is quite controversial, quite widely used, and I will start with the disclaimer that so when we talk of COVID therapeutics, everybody has an opinion. Everybody thinks he or she is an expert, but nobody yet knows what actually and what surely works. So that is very important. So what I will start with is, I will talk only about evidence. What evidence is there, I will present to you, and it is for you to make an opinion. You already may have an opinion. I would just give you some fodder to eat or fodder to think, and let us see what is your opinion at the end of it. So I will stick to time, but this was what started ivermectin. So that was this Bangladesh study, 12 milligram per day for 5 days. The results were published, preliminary published much earlier, but this full paper has come in January only in 72 hospitalized mild COVID patients. Ivermectin alone versus ivermectin plus doxycycline versus control. And the study said that virological clearance was earlier in the ivermectin arm, 9.7 days versus 12.7 for placebo. But surprisingly, the ivermectin plus doxycycline arm didn't have any benefit. It was 11.5 days. So now this study published in February. I would just tell you the gist that there was no virological early or virological clearance was not there with ivermectin in this study, which used for 400 microgram per kilogram within 72 hours of onset. But self-reported anosmia, hyposmia, cough, and viral loads were supposedly lower in those patients who had ivermectin. So this was published in February, and this meta-analysis, although this was published in way back in 2020, October, November, but this said, but there has a definite all-cause mortality reduction with ivermectin. But also they said that yes, there is a significant clinical improvement compared to usual therapy. So this was what was there, but yes, they also emphasized that the quality of evidence was very low. So this was published way back in October, November. The Bangladesh study was published in January. The February study says no effect. And this is another meta-analysis which was published in January 2021. Andrew Hill and co-authors, and Andrew Hill has been working quite a lot on ivermectin. And this study said that ivermectin also reduced inflammatory markers, all the 3: C-reactive protein, D-dimer, ferritin, as well as there was a 75% reduction in mortality. But however, they said that most of these papers which have been published, they are not peer reviewed, and therefore the meta-analysis is subject to confounding issues. So this is important. This was in January, and now this was published in 29th March 2021. And again, ivermectin did show some mortality benefits according to this meta-analysis. But again, they said the data is quite small for us to analyze, and there may be better designed trials should be there. But on the top of it, 2 days later, 31st March, WHO issued an advisory that ivermectin should only be used as a clinical trial agent and not otherwise. But what did they say actually? So if you see, they said that there is evidence on whether ivermectin reduces or whether it reduces the need for mechanical ventilation, mortality, hospital admissions, and time to clinical improvement. The evidence that exists, they didn't say that there is no evidence. They said evidence is of very low certainty. And they gave the causes as small sizes and methodological limitations of available trial data, including the small number of event points. So this is important. Whenever we do clinical trials, we understand we want endpoints, hardcore endpoints. So that was the problem. And probably I would say the data of ivermectin is spread over the whole spectrum of diseases, mild, moderate, severe. Plus there is a confounder for prevention, prophylactic effect also, which obviously the WHO recommendation did not assess because it was considered to concentrate only on evolving treatment guidelines. But simultaneously, as has already been discussed, but you see there is a strong recommendation for corticosteroids and a conditional recommendation for remdesivir as well as anticoagulants, and against a strong recommendation against HCQS and lopinavir ritonavir. So these are the agents which the same WHO recommendation says, but they say ivermectin, the evidence is of very low certainty. So it is not against, but they didn't make a recommendation. They steered clear and said that it should be used. The further trials are required basically. Now this was published last month, 26th April. This is again a living systematic review published in BMJ. And to cut the story short, it said there is no confirmed benefit of using ivermectin. The last three words you can say, the evidence remains very uncertain. Now, this is again on the contrary, this is again another live meta-analysis of 56 studies which are there. And this is available online and this is updated every few days. So ivmmeta.com, if you go through it, it has a conglomeration of early treatment as well as prophylactic studies. And you can see the respective figures are there. Early treatment, 97% positive effects in 37 studies. And results were positive, significant in 26 studies. Total, they evaluated 56 studies. And again, when they concentrated on only the most serious outcome, for early treatment, it was 78%. For prophylactic, it was 85% reduction or 85% improvement. Similarly, mortality reduction in early treatment of with ivermectin was 81%. And in prophylactic studies, mortality reduction was 96%. And if they analyzed only the RCTs, the 17 RCTs, the positive effect was seen in 100%, all the RCTs, according to them. And estimated improvement is again 73% when initiated early treatment and 83% prophylactic studies. And the last bullet you can see, probability that ineffective treatment generated a positive result is 1 in 2 trillion. And there are about 12 zeros before that 4-1 and the p-value is counted. So they further said, this is probably my last second slide, and they further added that the evidence for early treatment is 78% in favor, late treatment 46%, which is not of very significance, prophylaxis 85% with ivermectin, mortality 74%. When you talk of only RCTs, it is not 78%, it is actually 66%, and all studies taken together is 72%. And the number of patients for all these groups when totaled is 18,447, which is a sizable number. And then they go on to analyze what drug has been given an approval by various agencies and how many studies. So budesonide, UK, one study, 17% improvement. Remdesivir, one study, major, but yes, we have a couple of studies more now, 31%. Remdesivir, one study, 66%. So they are all emergency use authorization. But for ivermectin, probably the yardsticks are different. 56 studies, 18,447 patients, improvement in 72%, but still we want more trials. So I agree with it. So I also conclude, I would say, yes, ivermectin is a trial drug. Not only ivermectin, all drugs are trial drugs. Every drug has received an emergency use authorization. You cannot advocate remdesivir, you cannot advocate the cocktail monoclonal antibodies, they are all still trial. They have been given because it is a pandemic, everybody is panicky and everybody wants to use something. So the exact role, as I already said, in mild, moderate, severe, or for asymptomatic patients, or for prophylactic dose as reducing infectivity, that ivermectin has been used. Nobody can tell, because especially in India and probably in many other countries, because of the panic, everybody is actually taking a whole lot of already a cocktail of drugs. 3 antibiotics, ivermectin, favipiravir, everything is being taken. So even in patients who are under clinical trials, it is very difficult to analyze the data. because they are taking some kala, Ayurvedic preparations and everything on the board, over the counter or under the counter in some way or the other. So that is the problem. It will be very, very difficult to analyze any data right now. Unless until we have very admitted patients, yes, you have some control. So evidence right now is inconclusive. And I would say use outside of clinical trial mode seems unjustified right now. Whatever drug we use, we should have the conviction that yes, it is benefiting, then only we should give. Whether it is erythromycin, whether it is remdesivir, whether it is doxycycline, or whether it is ivermectin for that purpose. Well, thank you. I think that's my last slide. Thank you so much.
Thank you so much, Rohini. Thank you so much, Anupam, for making it that so interesting. We now move to the Q&A, and it's a privilege for me to invite our two moderators, Dr. Sai Praveen Harnath. He's a pulmonologist and a critical care specialist working at Apollo Hospital, Hyderabad, American board certified in internal medicine, pulmonary medicine, critical care. He's also the medical director of the Apollo E-Access Tele-ICU services. Dr. Rajesh Chawla is a senior consultant in respiratory critical care medicine at Apollo Hospital, Delhi, past president of the Indian Society for Critical Care and National College of Chest Physicians, and the former chancellor of the Indian College of Critical Care Medicine. Over to you, Sai and Rajesh.
Hi, everybody.
Before we open the Q&A, I just want to acknowledge the presence of Professor Om Ganda from Boston, from the Joslin Clinic, one of our esteemed executive committee members, and Professor N.K. Ganguly, who is also an esteemed member of our executive committee and former Director General of the ICMR, for their presence. Over to you.
Thank you, Anupam. Thank you for the speakers, the moderators, for an exceptional webinar. Clearly, we're running late. People in America, late breakfast. People in India, late dinner. And Australians, maybe a late midnight snack. But we'll try to be really quick and try to go over the highlights of what everybody's spoken. So as you know, there are several therapeutics which are out there, and we know that oxygen works, we know steroids work. Beyond that, everything else is questionable, and we are trying to sift through the evidence to find out, does it really work? Dr. Ram had to leave. I'm not sure if he's still on board, but he had to leave for another meeting. And as you know, everyone's very busy giving talks and trying to educate. But one of the questions for Dr. Ram Gopalakrishnan was about the role of remdesivir in relation to the CT scan. And there's been some talk about a more severe CT scan. You need to use remdesivir early. But based on my chat discussion with him, it sounds like there is really no clear link between a CT scan image and the use of remdesivir. So I'm going to kind of halt with that question on remdesivir. Other than the other question was, I'm going to direct this to the baricitinib speaker about the role of remdesivir and baricitinib together. Now, we know that remdesivir is not to be used for a prolonged amount of time. So when you use baricitinib for 14 days, how does that fit in with the remdesivir? And we'll jump to that question once Dr. Rajesh has had a chance to introduce and talk about the next question. Thank you.
Do you want me to answer it right now, or?
Go ahead. If you're right on, please go ahead.
Okay. So I think what we need to understand is that was the ACTT2 trial, which did, it had a lot of modalities in it, on which it used the remdesivir for 10 days and it used the baricitinib for 14 days in that. So it does not make a recommendation that this day one and that day one has to coincide, but normally you start using them together. And the baricitinib goes on for 2 weeks, whereas remdesivir stops in 10 days. Now, the emergency use authorization was based just on this. And I think that was the question. It says, the speaker mentioned it can be used with remdesivir only, but to use it for 14 days, but remdesivir can be used only before 10 days. So I think that's what I could make out from the question. The other one was, if baricitinib needs remdesivir to act, it does not need remdesivir to act. It is basically just there as an add-on because it was just what was found out. So it's not due to the mechanism of action. It was just found that when you use both, the time to recovery was shortened. And that also you saw that from the numbers that it wasn't a big rate. It was just a modest improvement. So is there a trial comparing Bari with remdesivir versus remdesivir alone? The answer is no, but there is another trial where you have, it's called the COVID barrier trial, but I didn't bring it up because there wasn't any, meaning that trial could not be continued because there was no benefit there. That's the answers I can give you right now. I mean, I can go.
That's very good. I mean, that's very helpful, Dr. Balaji. I think that clarifies the main question we've had is, you don't have to start them at the same time, but the durations are as defined, 10 for REM and 14 for Barry. Thank you so much. Dr. Chawla, do you have your turn next, please?
Thank you, Anupam, for calling on the meeting. And, I am a clinician because a lot of clinicians are watching this show. And we have thrown so many drugs. Which drug do they use? Ravi, are you there? I'm going to, you have.
Sorry, Ravi had to step out as well. So it's largely the two of you are going to have to do this.
Yeah. We'll answer. If I am a clinician, I have a 2DG, I have Tocilizumab, I have Itolizumab. I mean, people watching, they must be a little confused what to use. So let me first go one by one. I'll ask the question on Itolizumab to another person. So Tocilizumab, I think the most important thing about Tocilizumab is the timing. I think COVID, we've learned, all of us sitting on this panel and watching this, is when to use it. If you delay, then it never works. If you are right on time, that is the, so when to use Tocilizumab? How I do, I'll ask Sai also, when does he use Tocilizumab? If I've given Remdesivir and steroids and patient is on this for 3-4 days and he's deteriorating, I start thinking of this drug, and that's how I introduce. And I found that and be cautious about infection. I always do, what I do is the Remdesivir and steroids, I get a Procal, I rule out active infection clinically as by Procal, and then I go on to Tocilizumab. So Sai, where do you use?
Exactly the same, Rajesh. It is my second line drug if things aren't working with the steroids. Generally, with the last few months, with the amount of shortages, generally, even if I wanted to use it, I've not been able to use it. But most places, they have been using it as when things are getting worse. And that does require a bedside evaluation. Despite wearing PPE, despite looking at a patient from a distance, I do a lot of remote intensive care, but it's very important to monitor the patient very closely because the respiratory rate, the oxygen requirement, these are dynamic things and you need to catch them early. So it's the clinical medicine part has not gone away despite all the distance we have with the PPE. So I think that's a great question. I think I want to segue right there into the Itolizumab because there has been a question about Itolizumab, when do you time it? So I have had a situation where we had to use Itolizumab when the Toci was not available and we timed it around the same time. Would the speaker be able to comment on the timing for Itolizumab?
Pooja, would you like to comment on that, please?
Yeah, so from what I was, because I will be honest, we don't use it in the States, Tocilizumab. We use Tocilizumab, but not Itolizumab. But from what I was reading and everything, it's again about timing. And it looks like they've done it when the patient got intubated or was just admitted to the ICU. That's what I read in all the thing. It was all about giving it when they have just a worsening oxygenation saturation. So I think it's very similar to Tocilizumab, where it's like when the patient clinically deteriorates, that's when they want to give it. It's the same with the Tocilizumab. But I personally can't tell you from experience, but from what I read, that's what it seems like.
So that's great. Rajesh, go ahead, please.
Yeah, you see, if I have both, I have Tocilizumab, I have Itolizumab. Pooja, which one will you choose? Suppose you have both of them.
It is, if I had both of them, I think I would actually, from what I was reading, Itolizumab seems like it's a little bit, could be a possible potential to give. Obviously, we all have experience with Tocilizumab, and it's been, from my experience with Tocilizumab, it's a hit or miss. Sometimes it works, it doesn't work. But from the limit, but the problem with Tocilizumab, there's such limit data. There's not a lot of information from what I was reading and doing all the research. They have only a phase 2 trial, only 2 countries use it, Cuba and India. So it's really hard to say which one to give. But at the time, you have to, I guess it's going to be a clinical judgment based on how the patient is, what the clinical status is, and what you can give them.
Okay.
Great. Dr. Balaji had raised his hand. Dr. Balaji, you want to comment on that?
Yeah, I can understand the difficulty going around there, but I can say from where I come from, it's been made very easy for us. The simplest is if a patient has an oxygen requirement and if he's heading towards high dependency or intensive care, that's when Tocilizumab is considered as per our recovery trial advice. The rest of them, we just depend on oxygen and dexamethasone. I know a lot of people might disagree with that, but it has worked in the UK. The Remdesivir was done initially, but it's fallen out of repute at the minute.
I would probably use Tocilizumab if Tocilizumab is not available to me. I would not use both of them. Sai, what do you say on this?
I agree. I mean, I am a kind of a Tosi fan mainly because we have a little more data. But honestly, at this point, we are still waiting for the head-to-head comparisons, which may never occur. And I think the reality is there is so much of practice-based medicine that has happened. It's worthwhile that an investigator or many investigators, perhaps from this group, look at the data that's already been accumulated from practice and see what worked. It's going to be an observational trial, maybe even retrospective, but the numbers are so gigantic. I mean, there are millions of people who have taken off-label use of these drugs that there should be a signal that should get picked up even by an observational trial. So I'm hoping somebody does that. So I'm going to jump, Rajesh, in the interest of time. We're running really late to talk quickly about the monoclonal antibodies. Now, one of the questions people have asked is, how do you actually time the monoclonal antibody? And that was, I think, pretty clear in the indications itself in terms of timing it extremely early. And I think the other part was, how do you actually decide which one to use, given that there are 3 out there in terms of combinations? Is there any comments on that in terms of which antibody to choose?
Sanjay is not there?
Yeah, Sanjay should be there. Well, in India, it's kind of easy. You just have one. So, and that also 48 hours old.
Correct.
So I think he's not.
Okay. So, I mean, I'm guessing, yeah, the Indian guidance is good, but I'm thinking that newer one, if it gets released, it's a single dose. So that would be, I guess, helpful. The other part of it was about splitting the dose of the monoclonal, because the way it's packaged, you can potentially give it for 2 patients. And I think that's again under discussion based on the weight of the patient. Rajesh, I'm going to let you take one question from the chat box in relation to what we were talking about, the bevacizumab. What's your experience and what do you think about bevacizumab usage?
Somehow I haven't used this drug because we have always availability of Tocilizumab. So we have in our hospital, but they say that it is less immunosuppressive, probably a little safer drug, but I don't have experience with this drug.
I've seen people who have received it. Most of them have had very bad CT scans. I didn't see that they got better because of it. Almost always they had already received it and they hadn't gotten out of the hospital. So I'm not sure if it helped in some way. I don't know if there's an actual signal that it improved their health. I'm going to switch really quick to the...
Sai, there are a few pediatric questions. I was just wondering if Namit's going to volunteer to answer 2 or 3 of them. We can shoot them. So Namit, Sai will come to you next if you're on. But go ahead, Sai.
Okay, yeah. I can switch to pediatric stuff. Are you on, Namit?
Namit? Okay, we'll give it a minute or so, but Sai, carry on.
Okay. Sure. So I think the last minor topics, I would call them, one of them is the ivermectin, which was a very good exposition by Dr. Anupam. Now, I think we're going to have a parasite-free India, as I call it, because so many people have taken ivermectin. But at the same time, do you think there is any signal that ivermectin might be helpful in people who are very severely ill? I know we've been talking about early use, but is there any role in severely ill patients?
Well, that is one of the things which is very pertinent, and I would say that it has not been probably tested in very severely ill. It has been tested for mild cases and as an over-the-counter drug, and anecdotal reports or not anecdotal, but yes, prevention has been taken as surrogate by India. That is why actually it has not been given approval, because the support data that we have is not robust. So I don't think it should be used for severe conditions, severe COVID, definitely. No.
Great. Thank you, Dr. Dr. Namit is here, I think. Right?
And Namit is on.
Hi, Namit,
Yes,
I think we have a bunch of pediatric questions for you. One of them was, how do you recognize it in infants and what can you do for kids? And they're talking about the 3rd wave hitting kids more. What do you think about that? And maybe a line about the MIS-C syndrome.
Right. So how do you diagnose it? I think it is just a non-specific symptomatology, just like any other viral illness. But with the current wave or the surge of cases, you just have to have a very high index of suspicion. So anyone with the fever, cough, breathlessness, you think of COVID. What about the 3rd wave? We don't know whether it's going to come. We hope it doesn't. If it does, we just have to be prepared. I don't think it is going to be a huge proportion of kids, out of proportion, I would say. If huge numbers are affected, kids would probably be affected in more numbers. I hope not. I think we'll be prepared enough for that. You said a line about MISC. It's a multi-system inflammatory syndrome in children, also called PIMS-TS. We are seeing a surge right now. Our ICUs are all full of MISC patients right now. Luckily, most of them respond very well. And this time we are seeing, maybe with the more awareness, people are getting referred much earlier. In the referral ICUs like ours, we get mostly children who have significant cardiac involvement, but thankfully they all respond very well to treatment. So again, a high index of suspicion, children having fevers going on for more than 2-3 days with organ dysfunction, sometimes just severe pain, abdomen, lots of gastrointestinal symptoms. All of these should alert us towards a possibility of MISC. Mind you, we have a lot of typhoid and other diseases running simultaneously as well. So you have to first rule out those as well. We have had a couple of cases where we started treating as MISC, everything fitted into MISC, and 2 days later you have a culture which is growing Salmonella typhi. So that too is there.
Perfect. Thank you so much, Doctor. Dr. Rajesh, you want to take over?
You know, Shushmita, is she there? You know, I have a question for you on Favipiravir. You know, this drug, a lot of people used, and what is your, I mean, are you using this drug? Because I have used this drug quite a bit, and my opinion is that there is reduction in the fever faster in the group I gave. I gave it to a very large number of patients. Shushmita?
Yeah, so I have personally not used it, but I have a lot of patients, who come to the OPD. What I've found, and this is all clearly my personal experience from what I've found, is that when general practitioners and practitioners have started the medicines way early, from day 1 or day 2 of illness, then patients' effervescence has been much quicker. They've started to feel a lot better, but a significant proportion of people do end up coming to hospital. And at that point of time, their LFTs are deranged, they have transaminitis. And then the question comes whether, they will at all benefit from Remdesivir, and they don't get it for defervescence. But definitely the milder ones who have started early, symptomatically, they have been better. I have personally never prescribed it.
So, question for Dr. Sunita on the 2,3-DG.
Sunita's off. Sai is going to cover for her, but we've got Ravi back and we've got Sanjay back. So, we can go on the monoclonal option to Sanjay
after
you finish 2G.
Question, no?
Okay.
I'll ask
And of course, sure. But I think 2G, you better cover Sai because,
I mean, honestly, very brief answer. Experimental. I've personally seen about 3 patients who got it. I want to say that yes, their oxygenation got better, but that's very anecdotal. The data still needs some clarity, and I think we'll just have to watch and wait. It fits in the same category of pretty much everything other than steroids and oxygen, in my view.
So I think we are done with most of the questions. So can I summarize?
Yeah, before that, Rajesh, I had a couple of questions. One question for Sanjay. Sanjay, we have one monoclonal antibody preparation. What if we have more than one? So which one would you go for? I mean, or do we have enough data on the Lilly preparation?
So the Lilly preparation, thank you for posing the question. I'm sorry I was not able to unmute myself. I'm driving back to work. So so the Lilly preparation, the first one which came out, the bamlanivimab, that has been off the market already. It's not on April 26th, the EUA was cancelled. But the combination product from Lilly, the cocktail with bamlanivimab and the itesivimab, that has been available. But as I said, the variants are more frequently reported on bamlanivimab and the itesivimab combination, the cocktail. So it is not available in 8 different states in the US because of the variants presence. And that's the reason I was talking about the geographical variation, and you should be aware of that. And CDC has come out with the guideline and a web page to document that. So that's not available in India anyway. The next one is the Regeneron cocktail, which is available in India by Cipla, distributed. So that is actually very well documented to be acting against the variants as well, including the Indian variant. And that would be my go-to drug, even though there is no recommendation from the expert panel about which one to use out of these 2 cocktails. But in my opinion, that would be probably a good one to go. And the last one, which just came out 2 days ago, that has also been reported to be active against all the variants, including the South African variant, the Indian variant, the Brazilian variant, and all. It is still not yet out in the market. So that would be something to see, watch for in future. That would be the Tocilizumab.
Great. Before you close, Rajesh, we also have Dr. Bakul Parekh, immediate past president of Indian Academy of Pediatrics. So Bakul Bhai, if you want to make some closing remarks, then Ravi to close, and then Rajesh final summing up. Bakul Bhai. So while we get him, Ravi.
Should I ask him the question?
Yeah, sure.
Yeah, Ravi, are you there?
Yeah, he's there.
No, I can't hear his voice.
Yeah, he's there. He's on.
Ravi?
He's just unmuting.
Yeah. Ravi, there's a question for you. Which of these, so many drugs you've heard the whole day, which one of these you use in your practice?
Sounds like
Ravi,
we have
Ravi, unmute yourself. Unmute yourself, please, Ravi. Yeah. You couldn't hear? So what do you use in practice was the question.
Yeah, no, sorry. You had to unmute me, Anupam. Yeah. I was host unmuted, so host muted, so to say. So I think what Rajesh is asking is actually a point to be made to the audience. The point is that we have two types of drugs. One which has international data, which is debated by all over the world, and we have our endogenous collection out here, which is coming up also in bits and pieces. Internationally, if you look at it, it's all becoming keep it simple, minimalistic medication right now. Oxygen, steroids, a whiff of Remdesivir plus minus, a whiff of Tocilizumab, minimal anticoagulation. There's nothing more which the minimalistic guy is going to say. Indian edition, a spot of interferon, a little 2G over there. Let's look at the monoclonal antibody. Currently, I think at the end of the next 2-3 months, we're going to be left with these 4 or 5 simple things, good critical care, and leave it over there. That's my feeling at this point. None of these are going to stand the test of time. We're playing with baricitinib, we're playing with tofacitinib, we're learning tongue twisters out there, but minimalistically, except for these 4, maybe the monoclonal antibody will do something, but I have a sinking feeling that a new variant will get rid of it. So India's contribution to the world has been a vaccine, and India's negation to the world will be this variant, and we'll be playing this game for a while with minimalistic, keep it simple COVID medicine, to put that phrase into perspective.
Thank you, Ravi. So Anupam, can I go ahead?
Yes, please summarize, Rajesh. Yeah.
So we've heard a lot of medicines, a lot of trials, and a lot of drugs which are available to the clinician. At the beginning of the COVID, we didn't have any one of them, and we were very simple. But now we have so many of them, and we are much more confused. So let me put it the current practice, which I feel I do. Maybe it is suitable to many of you. If it's a mild patient, and I'm talking on today on the 28th May, that 29th of May to 2021, that if I have a person, in addition to the supportive care, if he fulfills the criteria for monoclonal antibody and he can afford and comes within 48 to 72 hours, we should offer this drug. So this is, and we have only one monoclonal antibody cocktail available, so we can give this cocktail to them. Then Favipiravir, ivermectin, you heard there is a different view. People have not much evidence for Favipiravir, but there are some anecdotal evidence that it has like Dr. Sushmita said, there is a early defervescence and early clearance of symptoms. Ivermectin, very little quality data, and the one from Bangladesh, and then as was summarized by doctor, that probably there is some effect if used early. It doesn't have much side effect, but they have a plus minus role. One can use it, but have really not been found to be extraordinary drugs in the milder cases. In a hospitalized case, if you have a patient who is hypoxemic, of course, since even now the current practice is to use Remdesivir and steroids without doubt, although Remdesivir has been taken off the US and other markets, but in India still people are using. Now when patient continues to be hypoxemic and continues to worsen, as we discussed, you have a drug like Tocilizumab or Itolizumab, depending on the availability, you could use this. The baricitinib can also be used, particularly in patients who cannot be given steroids along with remdesivir. Not much experience all over India of this drug, but still there is a trial which has shown its efficacy. As for the 2,3-DG, still very few trials, not very high quality trials, but if it has to be given, it should be given early. And then I think I'm done with most of the drugs which are available. So let's hope with the time we have more clarity on these drugs and we have the clarity on which drug to use in these patients. And I hope and pray that we do not have the third wave and we are done with COVID now. Thank you, Anu.
Thank you so much, Rajesh. Thank you so much, Sai. This has been brilliant. We had planned for 60 minutes. We've gone to 120 minutes and we could carry on. But thank you very much to all the speakers, the moderators, and all colleagues from 12 countries who've joined. Just wanted to invite you for 2 exciting sessions that we have. We are going to have Shri Gaur Gopal Das talk to us about how to keep calm. And as you know, he's a great spiritual speaker and, you know, has his way with a lot of wit. He comes on next Saturday, and on next Thursday on popular demand, we're going to have to discuss muco. So we're going to have a dedicated session on mucormycosis. So thank you very much. Have a wonderful Sunday. God bless. See you next week. Bye-bye.
Bye-bye.